All right. So thank you, Dr. Brandt, for that wonderful talk. And I'm going to be building on that and talking about some similar elements, but maybe a few different aspects as well. And I was tasked with talking about the glaucoma data space, what data requires integration and why. Oops, sorry. No active commercial disclosures at this time. So three major components of what I'll be talking about today. One is extracting data at scale for glaucoma research. So you heard Dr. Brandt talk about, okay, we need decision support, we need easy to use predictive analytics, ways to help guide our busy clinicians in the clinic. But all the different data streams that we have, how do you develop those models? How do you build those predictions? And I'm going to talk about some of the work we've done to try to make that easier and also some of the barriers that we've found. I will talk about one use case where we are trying to bring a glaucoma AI model to the point of care for clinical decision support in glaucoma and also the challenges we face there. And then finally, in talking about some of these databases where you can integrate ophthalmic data with data from systemic data, pharmacy data, et cetera, I'll talk about a few examples. So just as an overall background, I think Dr. Brandt's already given a lot of preface to this, so I won't go into too much detail here, but really just wanted to emphasize this. All this happens with a background of data standards. We need like a common terminology or language to denote data very specifically because we have so many systems and different vendors and different places that the data are traveling. So this is important not just for clinic, which Dr. Brandt has talked about extensively already, but also for research and AI development, right? So AI models, we all know, are really data hungry. They need, and especially the models that we're using today, deep learning models, generative AI models, they work well with a large amount of data. But to combine data from different places is really challenging because they might be formatted in different ways. It's very difficult to share. And in addition, these days, with a lot of concern about data privacy and data governance, a lot of institutions are reluctant to openly share their data with each other. So there's a lot of emphasis on federated learning, distributed learning. In order to do that, the data elements have to mean the same things as in the different places. And so if you say, okay, I've got a model where I've got a certain weight for a certain variable, well, that variable needs to be the same across the different places. So you need standards to be able to accomplish that. So in order to do that, you need a common data model. And what is a common data model? It's a standard format and structure for representing data. And this allows that harmonization of data across different sources. And one of the most common ones is called the OMOP Common Data Model, or the Observational Medical Outcomes Partnership Data Model. This is a series of tables. It's a person-centric model, and it will have very standardized ways of denoting medications, encounters, conditions, observations, and so forth. And this has kind of been the data model du jour, and the data model used in a lot of the NIH data generation projects, such as All of Us, N3C, and Bridge to AI, which I'll be talking about later. The data model also harmonizes across different standardized terminologies like ICD codes, CPT codes, LOINC, SNOMED. So it's kind of an alphabet soup of different terminologies, but it brings it together so that you can harmonize data across systems. When you hear about bringing data together and doing data integration, very common term that you'll hear is ETL. And when I started my informatics fellowship, I was like, ETL, everyone's talking about ETLs, what does that mean? It means extract, transform, and load. So extract is you're extracting the data out of different sources, and it might be in different formats in different places. You're gonna transform it to a common representation. So for example, if you're bringing something into the OMOP Common Data Model, you're going to provide logic to say, okay, this data element from institution A, we're going to map like these values to its corresponding match in the OMOP Common Data Model. And once you've done that for all the sources, then you load it into your common data repository. But one thing that wasn't immediately obvious to me at the start, and that I've sort of discovered over time doing some of the data integration work, is that if you don't have a matching concept in that target repository, meaning if you don't have representation of that data in the OMOP Common Data Model, the data just get dropped. And so this is actually a challenge for us in ophthalmology or eye care and ophthalmic data, because there's not a lot of representation for some of our data elements that they just don't get transferred over. And so you'll have these big data warehouses with all the EHR data for many years across different places, and there's not any eye data in there. So this is a real challenge for us. So one of the first things that we have a group through the AAO doing data standards, and we actually created a separate group through Odyssey, which is the organization that oversees the OMOP Common Data Model, to specifically focus on eye care and vision research. We started with a couple people, and now we have over 200 members. And one of the first things we did was looking at gaps in common EHR vendors and see whether these data elements that we use, which, obviously here we're using them day to day in our clinical documentation. They must have some value to clinicians. How much of that is actually in the OMOP Common Data Model and able to be integrated into these large data warehouses? So we looked at the different fields and values, and what we did was use this terminology browser to see whether it was in the OMOP Common Data Model, and then for everyone looked at the OMOP concept name and whether it had equal representation, or wider or narrower, and we would denote why it was missing. But the main takeaway here is that only about a quarter of eye exam data elements had an equal match in the OMOP Common Data Model. It means 75% of the data that we're routinely collecting in our ophthalmology clinics are not easily mappable to these common data models and are not being incorporated into these data warehouses. If you want more information about this, we did publish this work, and more recently looked at the Cerner EHR as well. Similar results, it was like a quarter or so of data elements that had an equal match. For glaucoma specifically, we've actually done a lot of work in digging a little deeper, looking at exam elements that are specific to glaucoma, as well as visual field data, how much representation and standardized terminologies there were for those data elements. And I just want to highlight Shaheen Halaj has been a research fellow in my group. He is applying to ophthalmology residency this year, but he's been a major force in developing, finding these gaps. And the good news is it's, a lot of times we're talking about, here's a challenge, there's a challenge. Sometimes it feels a little bit like Debbie Downer. My gosh, only a quarter of our elements have any representation. We have so many gaps. But the good news is here, we actually worked with a group of glaucoma specialists and the SNOMED International group, and actually developed new codes for the gaps that we found, went through this whole process, consensus building, presented it to AAO, the Preferred Practice Pattern Panel for Glaucoma, EGS, AGS, and we actually have added new codes for many of these gaps to international standards bodies like SNOMED and LOINC. So that was a real success story here, but it was years of painstaking work to do it. And so I think, this is a real problem when you're talking about, okay, we want to build these models, we want to help clinicians. We need all this data across different places to do so. Just informally talking to other people working in glaucoma informatics, it seemed like there were a lot of challenges to extracting data at scale for research in glaucoma. So in spring 2024, we had a workshop of glaucoma clinicians and researchers from 10 different academic institutions across the US. And we also had some industry representatives there, just to be able to share some of our challenges. I just have a list here of the common ways that we are currently doing this now. And just to dig a little bit into that, several people are actually still doing manual review. So I had a couple colleagues saying, I just have a team of medical students who go in and manually review the PDF documents, or go into Forum and pull the patients out individually and transcribe them into a separate spreadsheet. This is obviously labor intensive. It's not very scalable. Depends on how many med students you have, I guess. But there's also substantial risk for transcription error. Then the next step up from this is that there's some folks who said, okay, I made a Python script so that I could basically do OCR off the PDF documents. And we had actually done this in our group too, and there are several others out there, publications describing this, to parse the data out. This was, again, faster and more accurate than manual review, but still you're not utilizing the underlying raw data, source data, and it's still at risk for error. Anytime you have a change in the format, then you have to redo your OCR approach. Not ideal. So, the kind of higher level ways of getting the data out would be actually getting that structured data out and the structured data reports, or even looking at the raw point-wise or pixel data. But here again is we run into this issue of portability, right? So the vendors, in order to do this, you have to pay for special licenses to do it. And so there are several institutions where they said, we just didn't have the funds to and the support to license the manufacturer's proprietary license to do batch exports. And it wasn't available for all imaging modalities. Even when it was available, sometimes there are limitations on the number of patients you could batch export at any given time. So you say, I have 10,000 patients, but I can only batch export, a few thousand or a few hundred at a time. And then this problem of people are concerned if you're using the PAC system for clinical care, you can't run your exports at the same time for fear of crashing the system. And we had many days where glaucoma physicians were really frustrated when Forum was running super slowly. And so the thought of adding any extra strain on that is not really tenable. We have a separate research PACs, but if you're trying to do anything with the routine clinical care PACs, that's another issue too. So now that there's this framework, a lot of emphasis on FAIR data principles, which stands for findable, accessible, interoperable, and reusable data. And I won't go into all of this here, but just knowing that basically we have challenges for every single aspect of FAIR data principles when it comes to glaucoma research, right? It's not that findable. Much of the data we need, visual fields, OCTs, are siloed in different institutions. They're not part of these big databases. They're not that accessible. You have to have special licenses and proprietary data types that are not easily interoperable. And then, reusability. There's also even different schemes when you're doing secondary data analysis of how you even represent visual field point-wise data. So a lot of challenges here. We did summarize this in a paper in Ophthalmology Science late last year. And so with that in mind, I'm going to talk about, even our challenges at one institution, let alone bringing data from different institutions, but at our institution, trying to bring a multimodal AI model for glaucoma that we had developed in our research environments and bringing it to the clinical care setting has been really challenging. And so here are some of the questions that came up, the considerations. How do we trigger the model? So you have all your patients coming through. How are you gonna say to the system, hey, this is someone where we need to run this glaucoma AI model? Because even in a glaucoma clinic, you're gonna have people who are post-op after cataract surgery, but they don't have glaucoma, right? So you don't wanna waste the computational resources on people who don't need the model. So are you gonna use diagnosis codes, imaging types, visit types? What are the minimum data elements you need? We had some patients who have a visual field the same day of their appointment. Some people have a separate visual field appointment. How do you incorporate all that data? We had this whole discussion with our enterprise IT teams about do we do single patient data extracts, bulk migration? What systems do we need interface with? There was an issue with time delays, so we said, okay, well, we can use this vendor-neutral archive. You got all these PAC systems, everything funnels to this vendor-neutral archive, so maybe that's a single point that we can simplify our data migration by going there instead of to the individual systems. Unfortunately, there's a 5-day delay as for the export from the individual systems to the vendor-neutral archive. So we couldn't use that either because we wanted it to be point of care. We want to say, okay, this person came in today, they got their IOP, they got their visual field or their OCT, and we want to be able to present the model output to the clinician that day. So we couldn't use the VNA because it's 5-day delay. FHIR resources. We need to bring in the data elements from Epic, like IOP, for example, to incorporate into the model. But the FHIR resources to do that, to bring that real-time messaging through, don't exist for ophthalmology data. And then finally, where are you going to run the model? We discussed doing it within Epic. Epic has a cloud computing system, but it cannot handle images. So we have to do it outside of Epic and bring it to a separate computational space and using Amazon Web Services, which is also what we used when we were developing the model in the research setting anyway. So we thought this would work well. But just getting the data there from the point of care Epic system has proved to be quite challenging. And we're not even talking about, the second part of the loop, which is once you create the model output, bringing it back to the clinician, putting it into the user phase, and then making some sort of recommendation secondarily. And so that part we haven't even tackled. It's just even getting the data out and running the model that has been, even that has been a challenge. So this just goes through all the different stakeholders that we've been engaging with to try to make this possible. Our IRB, we have a Center for Health Innovation that is run by our operational or enterprise IT teams, enterprise imaging, obviously Epic analysts, engineers around the data flow. And now we are bringing in an external vendor for the DICOM issues and sort of the PACS integration issues. So there's a lot of people, and like I said, it's very tough because the EHR cloud computing environment doesn't handle images. There's no FHIR resources, and these are all things I think we need to tackle before we can make point-of-care glaucoma decision support a reality. And here's the data flow that we ultimately came up with. And basically, these different images, we iterated on it. And now here's the new one. If this all looks confusing to you, I think that's just the point of these slides, that the incredible complexity, and these are the actual data flow diagrams that our IT enterprise folks are using in order to try and even do this in silent phase validation. And again, we're not even talking about bringing it to back to the clinician just yet. Even just to run it in silent mode has been very complicated. I will just mention that one of the things I think is a challenge for us is that there's not a strong financial incentive for glaucoma models for the health system. Right? So Dr. Brandt mentioned that the health system is the customer, not necessarily the clinician. We've done a lot actually in diabetic retinopathy because there is a HEDIS measure for diabetic eye exam. And actually at our institution, the primary care physicians were the most motivated to start a primary care-based DR screening program because they could get dollars back for that. There's not really a strong financial incentive for the system to build glaucoma models because there's not a very clear return on investment for them. There's not a quality measure. There's not a HEDIS measure that gives them money back for that work. And so I think that's something we need to think about as a field as far as getting more traction and getting support for this. All right, so in the last couple of minutes, I am going to talk about maybe a little more positively some of the success stories looking at various databases, and when we do integrate ophthalmic data and systemic data, how we can derive new insights. Dr. Brandt mentioned the All of Us program, and this is very similar to UK Biobank, lots of different data types, looking at 1 million people across the US. One distinction from the UK Biobank is that there was a real emphasis on, I put broad enrollment because the D word is no longer allowed in today's environment, but really trying to get a broad swath of people who might not have been represented well in prior clinical research studies. And this has been a real opportunity. As we know, glaucoma disproportionately affects folks from non-European ancestry, and there are a lot of patients represented in this database. I was very lucky to be one of the first people to publish a clinical research paper on predictive analytics for glaucoma from this data set. And so for anyone out there who's interested in getting access to data, it's very widely available, easily accessible, and has so much data for AI development. Most recently, this is Kiana Tavakoli. She's another fellow of mine who's also applying for residency this year, has been doing work with the genomic data in All of Us. And actually, GWAS in admixed American Latino ancestry populations was something that had not been really looked at in depth before. And so we've been able to do some work there and identify some new variants associated with POAG. And the stats there just give you a sense of how much genomic data is available, and it is quite impressive. Similar to UK Biobank, there is an initiative now to add ocular imaging. Mike Chang, who's in the room, has been a big advocate for that, and UCSD is one of the 3 pilot sites. We'll be adding fundus photography, OCT, and OCTA to the All of Us data set, and this is really exciting for future oculomics work. And on this theme of how do we bring different data types together, this was work that I did with Chi, who looks young enough to be applying to residency, but is an associate professor at Penn. And we actually met at this meeting 2 years ago. So she gave a talk on her basic science work and possible neuroprotective effects from GLP-1 receptor agonists in mouse models of ocular hypertension. And then I was talking about different databases, and we got to chatting, and she said, do you think we could look at whether GLP-1 receptor agonists have any effect on IOP in humans? And I was like, you know what? That's a really interesting question. It's a hard one to answer because like IRIS registry has IOP data, but not a lot of systemic medication data. A lot of the big claims databases don't have medication orders. They certainly don't have IOP. And then all of us, had, medication data, but not IOP. But we just happened to be doing a lot of this data standards work and had gotten IOP data into the UC Health Data Warehouse, the University of California Health Data Warehouse. And this was, you'd think it'd be easy. IOP is like just a number, but we had to map it to the OMOP common data model and then get it in. But anyway, we had like 200,000 eyes with IOP records. And long story short, we were able to look at this and saw actually that GLP-1 receptor agonist use was associated with a modest decrease in IOP in humans. So this was a fun translational piece of work that was only possible because we did all this data standards infrastructure and also a cool collaboration that came out of this meeting. So finally, I'm going to wrap up. I know I'm a little over time, but I'd be remiss not to talk about how data standards have accelerated network studies. So the Odyssey network has many databases, and again, with the GLP-1 receptor agonist, there was all this press around NAION risk. And the initial study was had some selection bias with a single neuro-ophthalmology clinic. But in a matter of weeks, we were able to do the same analysis across 14 databases, 37 million patients with diabetes. And we did find a small association, but it was much less degree than the initial paper. So I know I'm over time, so I'm going to wrap up, but basically suffice it to say there's additional databases. This is one, the AI Ready database from the Bridge to AI Consortium that includes a lot of retinal imaging, different data integration. It's not focused on glaucoma per se, but a lot of opportunity, and it's widely available. You can go to docs.aiready.org to get the data set. So I think there's a lot of benefits to this, and we are definitely in need of broad engagement to move this forward. There's so many streams of digitized data that offer potential for future AI applications, but so many challenges in actually bringing them together and bringing them to the clinic. Thank you. Just featuring new building, new baby, exciting times.